Hello everybody, I'm Milind Desai from the Cleveland Clinic, where I am the Vice Chair for Heart Vascular Thoracic Institute and I direct our Hypertrophic Cardiomyopathy Center. It is great to be here. So as we know, HCM has a prevalence of 1 in 500. And Mybpc3, it is an abbreviation for myosin binding protein C3, is the most common within this cluster of genetically inherited HCM. So it is very common. Almost a third, if not more, of these patients have this type of mutation that results in hypertrophic cardiomyopathy. An important finding in these patients, the Mybpc3 patients, is that they are missing about 40% of the protein that is key in maintaining appropriate functioning of the sarcomere, of the cardiac sarcomere. So that lack of a complete protein amount is what results in the downstream manifestation of the disease, including very thickening of the heart muscle, stiffness, etc. So that is the concept behind, if we replenish this missing protein, can we reverse or slow the progression of disease? So thus far, most of the drugs are not disease modifying. There's new cardiac myosin inhibitors that are thought to be potentially disease modifying. This is taking it to the next level where we are slowing the progression or perhaps even reversing the disease if everything works out the way we think it will. So basically what it is this is a very smart way where we are utilizing adeno-associated, so AAV9 virus, so adenovirus. So that's a common cold type virus which has been stripped of its own DNA and engineered to have a cassette inserted within this the virus, which basically has the DNA trigger for Mybpc3. So essentially, once you do this one-time infusion, the infusion goes straight to the heart. It does not the virus does not have affinity for other organs. From there is a cascade of events where the DNA cassette is excreted, then DNA turns into RNA, RNA turns into the protein, the missing protein, and whatever that is thought to be excess is dissipated through the hepatic system. So basically, you are delivering a payload of potentially, you are delivering a payload that ultimately results in generation of the missing protein. So this is clearly an early phase, so phase 1 study. So this is the primary reason for the phase 1 study is to understand safety. It is not certainly, efficacy is an endpoint, but not the key endpoint. Safety and feasibility of doing this. So this is essentially a phase 1 study. There's 2-3 steps before that. The step 0, the way I look at it, is you have to identify, obviously, the patients who have this mutation, a truncating mutation, you're looking for a truncating mutation which results in loss of protein. You have to make sure there are no antibodies to the virus. So you have to have the right type of population, and obviously symptomatic hypertrophic cardiomyopathy patients. The first 3 patients that we are describing were all non-obstructive patients who had all undergone surgical myectomy, but they were still symptomatic despite relief of outflow tract obstruction. They all had advanced diastolic dysfunction, thick heart, etc. And essentially what we found was that the process, the logistics process in these first 3 patients was A, feasible, B, safe, and obviously it has to be done under the umbrella of immunosuppression, where we use prednisone and sirolimus over an extended period of time of multiple weeks. And then essentially what we demonstrated that not only was this feasible, but it was safe, and then we have been able to successfully wean all these patients off of immunosuppression. And in terms of the efficacy, again, mind you, efficacy was not the focus of this study. Efficacy, all the patients are in NYHA class 1, everybody is alive. Essentially, there is stabilization of function and biomarkers and some improvement, but this is still very early and small numbers. So all steps in the right direction. There were non-Tn-201 related adverse events, but everything was addressed. And as I said, patients are all off of immunosuppression and in class 1. Obviously, like any new drug or therapy development, it has to go through the obligatory testing. So phase 1 will morph into phase 2 and maybe, if needed, phase 3 trials. And then, look, if you are an optimistic glass half full kind of a person that I am, I tend to be, and let's fast forward 10, 15 years down the road, okay? And we have worked through the process, all the kinks, we have done the obligatory testing. This could theoretically be a one-time infusion where you come in, get this infusion, get monitored for a little bit, be on immunosuppression for a little bit, and then you could have slowed progression of disease, or in some lucky individuals, halt the progression of disease. So this is truly, if the process works, this has the potential of changing the game, the way we look at this. Not just this mutation, but it can pave the way for many other mutations and many other therapies. So the first data is on the lower dose. So the next part of the phase 1 study will be on the higher dose. We need to figure out what is the Goldilocks situation, what works the most efficaciously while maintaining the very optimal safety signals. So that's what's ongoing right now, and then that will morph into a broader patient population exposure, perhaps expanding to the rest of the world. So the obligatory next steps are already underway.